You've got it. You better stop it. Ooh. You've got it. You've got it.
This episode of the Ready State Podcast is brought to you by Cock Punch Coffee.
Look, our friend Tim Ferriss was famously maybe poisoned by coffee in the gym on a podcast we did once.
Yeah, I mean, didn't you feed him like 17 shots of coffee
Cold brew.
masqueraded as a cold brew?
Yeah, I was like, it'll be fine. And I want to believe that that was the genesis.
That was
of
a
changing
turning
his
point
DNA.
for him?
That's
It was
right.
a turning point?
And it gives me such pleasure all these years later to talk about Tim's personalized coffee, Cock Punch.
So this is, look, you guys, this is super high quality coffee. It has a really low carbon footprint. And who cares about all that? I mean, I do care about that. But most importantly, it's so tasty.
Yeah, it's really good. It's a good coffee. As you may know, as a follower of the show, that I famously will vacuum out coffee out of our espresso machine if it's not up to par.
Yeah, if
and the
it's not up
first
to
time
a
I
star
got
at
Cock Punch,
standards.
I was like, "Ooh, here we go."
Yeah, we
Like,
were.
Your
we
friend's
were
like, "Hey, I
nervous.
made here's my favorite thing," and I'm like, "Well, you just ruined my favorite thing." But I can tell you, I love and adore this coffee, and I love that Tim has taken 100% of the profits from the coffee and applied it to his foundation, which is dedicated to solving sort of intractable disease.
Yeah, it's coffee with a cause.
It's amazing. If you want to learn more, go to cockpunchcoffee.com/TRS and use code TRS for 20% off your first purchase.
This episode of the Ready State Podcast is brought to you by Gibboard.
Now, if you've never heard of the Gibboard, imagine sort of an upside down skate deck. It looks like a really flattened U and it has a slack line down the middle.
Yeah.
So imagine having your very own slackline balance board in your home, but it's beautiful and it's super fun. And the thing that I wanted to highlight is we were just hanging out with a friend who teaches middle school PE, right? And one of the things he's discovered is that they're having to teach a bunch of fundamental movement skills to these kids, balance, vestibular work. Like these kids aren't getting the things. They're not even playing sports anymore, like the dreaded PE,
Yeah,
right?
and they're missing out on a lot of the like free play that we all did in elementary school because
They're
of technology.
They're having to go back and make sure that kids are exposed to fundamental things, throwing and catching, eye movement, balance. If you add a Gibboard to your living room, you will see improvements in all of the motor function of your kids. Like this thing is probably the most important health metric thing you can do for your kids besides sleep by having it in your house.
Yeah, and it holds people up to 400 pounds, which means it holds Kelly. It only weighs 9 pounds. I was waiting for you to respond to that. And the other thing, it just looks cool. So we keep this thing right in our living room. And I'm telling you, every kid or adult that walks into our house, it's just sitting right there. And they're, you know, if we're cooking dinner or chatting, like people want to just get on it and play with it. Like people are
Yeah.
drawn to it, kids and adults alike.
We should know that, or should be noted that your mother comes in and balances on it.
Yeah. She's
And
almost 80.
That's all you need to know is that like Jan comes in and is like, oh, what's this? And starts bouncing around and playing around. I think what's great about this is it's disguised as a whole lot of positive things in the context of free play. And if you're a person working at a desk who's trying to stand up and move more, get one next to your desk. This will change your office culture, change how you experience, and you'll feel less stiff, you'll feel better, and you'll shred things you care about.
Go to gibboardus.com/TRS and use code TRS for $10 off any Gibboard. We are thrilled to have Dr. Mary Claire Haver on the podcast today. Dr. Mary Claire is a board-certified obstetrician and gynecologist, LSU Medical Center alumna, and UTMB residency graduate. She's also a certified culinary medicine specialist and Menopause Society certified menopause practitioner. In 2021, she founded Mary Claire Wellness, focusing on menopausal patient care. Her debut book, The Galveston Diet, launched in 2023, alongside thepauselife.com, a global menopause resource. With 4+ million social media followers, Dr. Haver is renowned for her insights and a #1 New York Times bestseller, The New Menopause, aiming to empower other women and demystify menopause.
Where do we start with this, Jay?
Man, I mean, I'll just start by saying that I have been a huge fan of Dr. Mary Claire for, 18 months or 2 years. And I think she's a legend. And I think it is amazing what she's doing for women's healthcare. And I'll also say, I think there are a lot of physical therapists, coaches, chiropractors, practitioners, many of whom are not women, who might pass over this episode. But I actually think from a practitioner standpoint, it's also super important.
Yeah, a couple things. One, it's really fun to have her in the studio.
Yeah, that was great.
Number two, 100% of you in the world have a mother or a grandmother. And it's so interesting to see how, initially we were discussing women aren't small men around performance with the work of Dr. Stacey Sims. And here we are just having the next step conversation of, hey, there is a lot of things that we've been taking for granted and really doing women a disservice with. And again, to your point, I think being a provider, practitioner, coach, having a lot of contact with someone can say, hey, I think we should explore this together, or here's some resources for you to see that if you can change how you're feeling.
Yeah. And I think for women who are listening to this podcast, I think I by and large are starting to realize maybe we haven't gotten the medical care we need when it comes to perimenopause and menopause. And I'm so grateful that there's this groundswell of information and practitioners out there on the internet and otherwise who are really trying to educate women, and not just educate women, but educate really busy physicians who honestly weren't taught this information in medical school or in their residency.
Really,
and so I think it's really cool to see Mary Claire taking this sort of like double-sided approach, right? She's working directly with women who are in menopause, but she's also launching programs to actually help physicians become menopause practitioners themselves and understand how to treat women who are in this phase of life.
I think it's interesting. Oftentimes when we think menopause, we think, the obvious symptoms that everyone's heard of, but there are so many musculoskeletal, psychoemotional symptoms, physiologic symptoms related to this phenomenon that happens to every person who's a woman. And it's not just about the symptoms today. I think one of the things I really love is that she's taking the systems approach to say, hey, let's go ahead and work on improving how you're feeling and your current biomarkers. But also, if we do some really sort of smart steps with a physician, we might increase the quality of your life and your
lifespan or health span. Yeah.
Holy moly.
Yeah.
I mean, we're talking about heart disease. We're talking about, dementia, just like, and for the next 30, 40 years of your life, let me just say it. This is the most important podcast we will ever do so far.
Yeah. And I just want to echo what you said. It was such a treat to have Dr. Haver live in the studio. And I think it made for a really fun and amazing conversation that I think everyone listening to this is going to enjoy.
Please enjoy.
Dr. Mary Claire, welcome to the Ready State podcast.
Thank you for having me.
So we don't get the opportunity to do a ton of in-person podcasts, so this is extra fun for us. So thank you for taking the time to come here. And before we get started, I just want to congratulate you, #1 New York Times bestseller.
Yeah.
We've learned from our agent that there's sort of a hierarchy of flexes in publishing, and being a #1 New York Times bestseller is a big flex. So huge congratulations.
It's in our category, which is advice, how to, miscellaneous. We're now on the list for 10 weeks straight.
Yes.
And this is a list that is typically dominated by males. And so it's a really big flex for womankind because we're still in there. And like last week, on week 10, we were #2 on the list. So this book is really speaking to people.
Major congratulations. It's
Thanks.
a huge deal. And, even though I love that book, I hope you at least knock down Atomic Habits for a little while, because we're ready to see something else at the top of that list, even though that's a great book. So.
And let me say, as a clinician and as a provider,
Yeah, they don't understand what they're seeing. So before we get into all things menopause, you obviously had a long career in life before becoming a menopause specialist, and as an OBGYN, and now you're an amazing businesswoman plus OBGYN. But how did you initially become interested specifically in menopause?
It was an evolution. I really thought for a long time I would retire and like die. I don't ever intend to stop working in some fashion if I'm lucky enough. And as a OB-GYN, I was a generalist. I loved delivering babies. I loved, the continuity of care throughout the entire reproductive cycle. But as I was aging and my patients were aging, I started to realize there seemed to be a gap in my knowledge. I loved everything I learned in my training programs, but I felt kind of helpless and clueless when my menopausal patients would come in because they had so many complaints. And outside of really hot flashes and maybe some of the genital urinary symptoms, I didn't know what to do. I mean, I was part of the problem. And I was that doctor. I really, now that I look back, realize I was probably a terrible menopause provider. And God, it took me stepping outside of the box and going, realizing I had a gap because I couldn't even serve myself. And I was gaslighting myself, my own symptoms, until I just woke up one day and realized this is menopause, and started down the rabbit holes and realized there's so much good information actually out there, but no one's talking about it. And the FDA, the American College of OB-GYN, the Menopause Society, they're much better than ACOG, but that this information is not being put forth in front of our clinicians in any kind of a meaningful way to extend the health span of women after reproduction.
I want to just advocate for physicians everywhere right now, because everyone comes from some place. And if your school, which is probably a reputable school, I'm guessing, no, I'm kidding. Of course, one of the things that happens is that we all come out of our professional schools, and if it's a blind spot for your education, how could you know? And then you get into just working, and here is this blind spot for you, but you're busy. And I don't know everyone, if you know the life of a physician, but you have 6 to 8 minutes to talk to a patient and have some meaningful conversations. And then you're going to go home and do all your notes and then educate yourself about, it's really, you can see how we can end up here, especially with a historically very patriarchal model, male-dominated AMA, right?
Right. And that is exactly what's happening. I don't want to lay this at the feet of any one clinician because I feel like everyone is trying to do their best. Certainly there's some who have personalities that probably should not be in patient care, but I think most went into it for the right reasons. You're a victim of your training, and we're just not emphasizing health after reproduction ends in female healthcare.
So we talked about your amazing book, and you wrote a prior book that was also greatly successful, called The Galveston Diet. So congratulations on that one as well. But why this book and why now? And the reason I ask is that, and it could just be because targeting on the internet is a real thing and I'm 50, but it seems to me in the last year, and I'm 51. I already forgot. It seems to me in the last year that I went from getting no information about menopause, perimenopause to all of a sudden
the algorithm found you.
Yeah, it's so it could be the algorithm, but it does seem to me like there's a real groundswell of interest and understanding around the research. And I know people like you have been behind the scenes in a way working on this, but am I getting that right? Is there like a groundswell, and is that why now? But why this book? Why now?
So Galveston Diet, the plan of the Galveston Diet, which I never should have called it a diet. Like in medicine, a diet is a pattern of eating. I wasn't thinking, a quick weight loss program. It was how a menopausal person could approach her nutrition. And as I was talking about the word menopause on social media and nutrition, people were flooding my inbox with more menopause questions. And initially, I'd be like, I don't know, I've never heard of that, like frozen shoulder or tinnitus, or, ringing in the ears, dizziness, palpitations, all these kind of vague. And then when 10,000 people ask you the same question, I'm good at picking up patterns, and I'm realizing they're not all making this up, this is real. And then I start meeting the Menoposse, cardiologists, psychiatrists, orthopedic surgeon, people who are all realizing, making these connections in their clinics. And we start digging through the research and realizing, wait a minute, this is more than hot flashes and night sweats and, some vaginal dryness. This is turning the needle to accelerating cardiometabolic disease and dysfunction. And we can intervene and make some serious changes here. And like the rest of the medical world's not catching up with us, but we're just going to keep pushing. And so I told my publisher, like, this book will sell. Like, it's not about selling the book. I need to get this information out there. People are screaming for it. And I think I can do it in a way. I'm going to use all evidence. I'm going to have, that I think we can turn the needle medically and start moving the regulatory agencies, the FDA, the ACOGs, so that this gets out in front of people and they realize. Plus, Gen Xers aren't putting up with this.
They're mad. They're
mad.
They're mad.
I need to just double click on Menoposse.
Oh, yeah.
So
Yeah,
just
can
like
you
I've never heard that before.
Yeah,
and
see,
I'm like,
I know
okay.
what that is because, again, the algorithm.
I hope that's trademarked somewhere.
What is the Menoposse?
So the Menoposse is a group of clinicians and thought leaders. They're not all docs, who are all like-minded in our unification of moving the menopause message forward in a modern way, so that we're not only improving lifespan for females, but we're improving health span. And that's our focus. And so we bonded together because we wrote the rebuttal together for the Lancet article that came out that kind of tried to push menopause back into the dark ages, and we absolutely refused. And so for like a month, we worked together every night, crafting this response, and then got it published. And then we called ourselves a Menoposse in the background. And then I started talking about it on social media, and it just kind of took
blew
off.
up. Yeah, it blew up. So I would like that. That was actually one of the questions I want to ask. So you teed me up for it. But and again, at some point we'll have to go into the W.H.I because that's sort of a mandatory part of this conversation. But
Tell everyone what W.H.I is.
the Women's Health Initiative, which we have a lot of questions about that. But could you talk a little bit about the Lancet article and sort of the blowback from that and sort of what happened there?
So the Lancet is a medical journal publication that comes out of Europe and the UK mostly. And it is what you would think of the New England Journal of Medicine, basically, in Europe. It's that kind of level of prestige. When you get published there, it's kind of a big deal. And so we heard so in the Menoposse, we have clinicians from Australia and the UK and Germany. And so they had heard on their end that this was coming out, but it wasn't going to be positive. Like the title, I can't even remember the title now, but it was, a modern way to approach menopause care. And it was a 4-part series, like huge, like lots of real estate in that journal. And then it was under embargo, but we got it leaked. We were able to look at it, and we were horrified about how they are approaching menopause and basically saying, the best therapy for menopause is cognitive behavioral therapy. Wow. And I love CBT. Okay. I think it is so important, but that is a psychological, basically if you outthink your hot flash, it's going to get better. So
I'm just going to apply that to men who can go get testosterone at 7-Eleven.
Yeah.
And just be like, no.
You need cognitive behavioral therapy.
You talk to the therapist about your, your
and if you
rectal
just
dysfunction.
outthink this, then it won't be as bad. Yeah.
Who
So
are those physicians? I know I don't want to say this, but like
So mostly out of
who are
the UK
people?
and Australia, and not all physicians, mostly researchers, and several of them were lead investigators on the Women's Health Initiative. So about a year and a half ago, if y'all remember, and like I know everything in the menopause world, the New York Times article that came out really shook down the Women's Health and the investigators in the W.H.I. and the fallout and the misinformation and the legacy of fear and misinformation that was left behind, right? And those researchers, I think, were pretty upset. And this, in my humble opinion, this was their pound of flesh. And there was a lot of language there, like those of us in the background know that they kind of got their feelings hurt. But let me tell you what, the Women's Health Initiative data set is a good data set. We have wonderful data that came from there. It was how it was initially reported, the legacy it left behind, but a lot of the things we know about cardioprotection in early menopause of hormone therapy, that's from the W.H.I. How much protein to avoid frailty in women? That is W.H.I. data. It's a great data set. It's just in how you manipulate and interpret.
So I heard that I think she's someone in the Menoposse, but she spoke before some sort of Australian government agency and was dismissed as like an internet menopause celebrity.
Hopefully they use the word hysterical too.
Yeah. But is that is the Menoposse as a group or any of you individually sort of being dismissed on that level because you are vocal, and then it's saying, okay, well, you know, you can't go into your physician from getting advice from your Instagram, you know, influencers. I thought that was really interesting because I could see how if you're an OB and all your patients are coming in with this information that they got from Instagram, that might feel annoying. But at the same time, from what I can tell, the people in the Menoposse by and large are highly qualified to be having this discussion. So did that actually happen?
It did. Okay. It did happen. And so, you know, it's an easy way to dismiss someone who has a large following, but there's also frustration that they don't have, you know, that they've basically been controlling the narrative of menopause care and did it within very small bubbles of academic institutions where they were very, very insulated, you know, and these are individuals who are taking lots of money from big pharma. You know, I don't want to be a conspiracy theorist. I use pharmacology all the time, but you know, there are financial invested, you know, these people's careers were built on this narrative. And here we are saying, we think there's a better way and we think there's a broader conversation here. And we happen to have built platforms on this information. And guess what? Patients are getting their information from social media, good and bad. But it's just an easy way to paint with a very broad brush. There's some terrible menopause influencers out there who are just spouting ridiculousness with no evidence. But I think that our followers check our credentials, know us and trust us. We're always quoting evidence. You know, you'll often see us with articles in the background.
Studies behind you.
Yeah. So we like receipts.
Yeah. Okay. So we've mentioned it multiple times now. So I think we should just dive into the W.H.I. And for those who aren't familiar, there is this deep history with the W.H.I. and lots of new information that have come out. But what I thought was interesting is I listened to your episode with Peter Attia, and I think he went so far as to say that this may have been like the biggest medical mistake in modern medicine.
Yeah.
I mean, not even
he
just
has said that
for women, but in all of medicine. So could you just give us the backstory for...
And I wanted to say that in my education, really reputable program from and I had incredible women lead instructors, zero conversation about, you know, we talk about frozen shoulder, you know, or adhesive capsulitis. You know, someone throws out, isn't it funny that it's called 50-year-old shoulder in Japan and in China, you know, and you're just like, oh, that's so weird. Why is it called 50-year-old shoulder? Moving on, you know, so this is important.
We should definitely talk a lot about the
But I just, my saying is, I mean, this is amazing.
Yeah, so just tell us the whole history and where we are now with it, because it's it's juicy.
In the, you know, and before the Women's Health Initiative, in the early 90s, mid 90s, probably 40% of menopausal people were, it was recommended across multiple medical organizations to recommend hormone therapy for the preventative benefits, okay? We knew, that data is clear, that women on HRT, remember, most women start HRT in their early 50s, right? Or late 40s, whenever they go through menopause, especially if they have severe symptoms of hot flashes. So 40% of women were given HRT. So we knew from that data that that group of women versus age-matched, socioeconomically matched women who weren't or chose not to get it or weren't offered it tended to have less heart attacks. They got them later, and they didn't die as often from heart attacks. So
a heart attack in women is a big deal.
Yeah, it's the most likely thing to kill a woman, even with breast cancer, is cardiovascular disease. And so 7-1 versus breast cancer deaths. So, so is that true data though? It's an observational study. Is this an artifact because women who get HRT tend to be healthier and wealthier? Okay.
Right,
so how do we prove anything in medicine? We do randomized control studies versus placebo. That is the gold standard. So we have the first time ever, the head of the NIH was female. And she puts this study together, $1 billion study. We were so excited. Like, we're finally going to study aging women. And they're going to look to see, versus placebo, does hormone therapy really decrease your risk of a heart attack? That's the whole study.
Forget quality of life.
No,
forget
that was
bone
not
density. This, I just want to point out this one thing.
Right. Now, they
not
measured
brain fog,
other
not
things,
anything, but I know.
But the outcome was it cardioprotective or not? So 37,000 people enrolled. They set the average age of 62. Why? Because women don't have heart attacks till they're older. So they needed to start with an older population, or the study would have been cost prohibitive to
Because
go
it would
on
take 30 years or whatever.
so long.
Right.
So they're much older, and they only studied 2 formulations. Prempro, which was conjugated equine estrogen plus medroxyprogesterone acetate, a synthetic progestin, or Premarin, which is just the estrogen component if you had a hysterectomy. If you have a uterus, we must give you some kind of progestogen to protect the lining of the uterus. This was not unusual. These were the top 2 formulations prescribed at the time. No one thought anything of it, okay? But they didn't study estradiol and progesterone, which are the bioidentical properties most of us in the Menoposse recommend today, okay? All right, so off they go. They enroll, they start testing, and within like 4 years maybe, they notice that in the estrogen and progestogen arm, they see a slight increased risk of breast cancer versus placebo. And that slight risk was, and I hope I get the numbers right, it went from baseline was 4 out of 1,000 women per year got breast cancer with nothing, with placebo, versus 7. So we had 3 extra cases per 1,000 women per year. In the estrogen-only arm, there was a 30% reduction in the risk of breast cancer. So here's where the first problem was. They call a press conference. They don't release the study. No one got to see the data. All the major news outlets were there. The headline of every newspaper, of every morning show, of every nighttime TV news, this was a big deal. It was the #1 medical news story of 2002. Estrogen causes breast cancer. And they didn't see a reduction in cardiovascular disease. And the world stopped turning. 80% of women threw their prescriptions in the trash. And the notion that estrogen is dangerous and will cause breast. So here I am, my chief year of residency.
Well, if I'm a man, estrogen is dangerous.
It's true.
It represents power. Like, I mean, this is insane.
Yeah.
So then all these women, so many things happened at that point. I remember like being in conference and hearing whispers of my professors behind me who were all like super well connected in the medical like regulatory agencies and like estrogen, you know. And at that point, all meaningful education and research just ground to a halt. Okay. That got propagated to multiple medical societies and like estrogen is bad, don't give it. And so we were kind of advised at that point, you only give hormone therapy literally if she's going to jump off a roof. Like if you want to try everything else, you want to do, you know, all these herbs and all these other things, and estrogen is going to kill her. So, but you know, she's going to die anyway, so you might as well just make her happy, you know? So, I mean, really. So no talk about quality of life. No talk about her bones. You know, we knew vaginal estrogen was safe, but that kind of got, so the FDA slaps the breast cancer, stroke warning, all the stuff on every estrogen product on the market.
Oh, like including vaginal estrogen.
Yeah.
Right. Okay. Which we can talk about that too.
Vaginal estrogen is the same. It's over the counter in Europe. Okay. You can just walk into the pharmacy and pick it up. It is so safe. It doesn't have any systemic absorption. Even with active breast cancer, you could use vaginal estrogen. But it stopped every conversation, every option. Estrogen is bad. I mean, tell me, the time that our estrogen levels are the highest are in pregnancy if you've ever been pregnant. And it's very rare to develop breast cancer during your pregnancy. Breast cancer develops when your estrogen levels are absolutely the lowest in mostly in postmenopausal women. Now, I'm not talking about you have a genetic predisposition, you've got one of the high-risk genes. That's a whole separate conversation, and that's a whole nother podcast. You know, I'm talking about the basic average woman. So now the data, they've followed those women. They kept following them, you know. The American Heart Association in 2020 went back, looked at all the studies, all the data, all the new studies that had come out. So much of the original W.H.I findings have been walked back, but that never made the national news. It gets buried. They're published in esoteric journals like the Green, the Gray, which are the big OB-GYN journals, the you know, New England, the AMA. No one is publishing this stuff. Okay, so every year, so here I go. My medical school, I got maybe 1 hour of a menopause lecture, which is the end of your periods. And we move on. So then in my OB-GYN residency, I maybe had 6 hours total of lectures in a 4-year curriculum. The vast majority of, well, slightly over 50% of my training was in obstetrics, which is important. Then we have gynecology is lumped in with everything else. Pediatric gynecology, GYN oncology, which is ovarian cancer, uterine cancer, cervical cancer, vulvar cancer. Then we had reproductive endocrinology, getting people pregnant, which is all that basically boiled down to. So when you think about, if you go to PubMed, which but for your listeners, is Google database for doctors, for healthcare professionals to look for good studies. You type in the word pregnancy, we have 1.1 million articles. Important stuff, good stuff. You type in the word menopause, we have 97,000 right now. Okay, so it's more than 10 to 1 of the brain power, the research dollars, the funding, the focus. And if you go to the NIH, they don't even have a menopause category. It's not a thing. So then you type in perimenopause, 7,000 articles of the word perimenopause mentioned in any research studies. That's kind of where we're starting from.
So one of the things I read, and I'm not going to get these numbers right, but when that in 2002, when the media picks up this, like the frenzy around estrogen being bad, there was really something in the way, I think the way that the media reported it was like a 25% increase in breast cancer, which really wasn't correct. That wasn't a correct interpretation. Like 4 to 7 out of 1,000 is a 25% increase.
All in how you interpret statistics. So we have relative risk and we have absolute risk. So relative risk is population risk. And most, even for me, who said, I have to think real hard about it sometimes. And so the increase is relative population increase versus absolute risk, which is what is your increased risk as a human being starting hormone therapy? And it's less than 1% increased risk of breast cancer per year. But when you look at population data, the relative risk is not really applicable to one human being. Right.
And it's so interesting because you see like a lot of women that I know who have 25 menopause symptoms. And again, this is all a conversation with their doctor, but maybe a 1% additional risk might be a risk they're willing to take in order to have quality of life, right? Like that doesn't seem like an unnecessary risk to assume 1%.
We're not training clinicians to give the complete picture. There are risks of being on any pharmaceutical agent, right? But there are risks to not being on it. And that's the part of the conversation that women are not being allowed to consider. And I think that's a horrible mistake.
And we're not even asking the right questions. What would feeling better mean in your life? How would the reduction or attenuation of your symptoms impact your relationships or impact your self-control or self-identity or low? I mean, we don't even ask
I was taught
questions.
This is just something women go through.
Let me ask you, let me just stop for a second. I have been trained by people like Stacey Sims that women are not small men. That's something I'm very proud of early in my physio performance education. We think differently, right? But there have to be some foundational principles to being a human being. So if I remove all the androgens out of a human being, a man, what would happen to me?
You would lose muscle mass, bone density, your mental health would deteriorate, you would become a shell of a human being. We have a hypogonadism, how it happens naturally in some men, or surgically for treatment of testicular cancer or whatever. And we know what happens. It's horrible. And your quality of life goes.
Is there, and I know that we're talking about it, I'm just trying to make this clear for everyone, are women so radically different that their androgens are so much more dangerous? I clear this what this whole conversation's about. But it seems like we have a type 1 error in our thinking that's so profound.
We've genderized hormones. Okay. Like testosterone is a human hormone. I have it, you have more because you're male. But like if I lose all my testosterone, my quality of life goes down. My bone density decreases, my muscle mass decreases. It gets much harder for me to stay healthy. My frailty level increases. When we look at the status quo, which the old menopause, like this old narrative is like, women are fine, but here's the reality, 3 to 1 risk of Alzheimer's, okay? And 3 to 1 admission to long-term care facility. So when my patients come in, we take care of the acute problems, right? The hot flashes, the night sweats, we get their life back. Then we start setting a course to keep what happened to your grandma? What happened to your mom? What are you trying to avoid? And so, if you have an osteoporotic fracture in your hip after the age of 65, even with surgical repair, 29% of women will die in that.
My grandma fell and broke both her hips. And now I'm like, OMG. Here was a woman who was very active, but just fell and broke her hips.
And what was her life like after that?
Holy moly.
Yeah.
Yeah. And one quick story for you is my mom, Janet, who is almost 80, but everyone always says, Janet just looks so good for her age. She looks like she's lean and good and she's so cute. Well, it's interesting. She had a hysterectomy in 1991 and was put on estrogen and thankfully never taken off. Whoever she's been working with over these, so my mom's been on estrogen since she was basically 50 years old. And it wasn't until I started following you and reading your book that I was like, I wonder if part of the reason Janet is so vital and functional compared to her cohort is, I'm sure it's lots of factors, but I'm wondering if one of them.
Can we get hashtag Jack Janet trending? That'd be great.
Okay, so I do want to go back because I want to dig a little deeper into the W.H.I.
Let me just say one thing. Yeah. I'm trying to just be this voice of partners. And if you don't even have a partner, you have a family member. I guarantee you have a mother and you have a grandmother. Guarantee it, like 100%. So this conversation is about your family. I just want to be very clear. Not your wife, not if you don't. This is about your family. So listen up, and you have to read this to understand how to care for your family.
So you said the W.H.I. walked back some important, or maybe the W.H.I.
So
didn't,
even
but the findings have been.
The findings have been
things?
reinterpreted. So
Yeah.
really the key things are that when we looked at the subset of women who started hormone therapy close to their menopause, like within 10 years of their menopause, there was tremendous cardiovascular benefit in those women. So it turns out that estrogen is better at prevention than cure. We know that there are estrogen receptors in the intima of our coronary arteries, okay, the lining of our coronary arteries, where the plaques form, where the calcification happens, where the atherosclerotic disease happens. And women who have estrogen, who have the gap their body goes without estrogen, that disease process gets attenuated, okay? Women are much likely to have osteopenia and osteoporosis if they have a small, we limit the gap of their body's time away from estrogen. Genital urinary syndrome of menopause. So that's vaginal dryness, atrophy, recurrent UTIs, that whole system from the bladder all the way, vagina, all that tissue is highly estrogen sensitive.
Do people think, you're just reeled off a whole bunch of symptoms that I don't think people connect to menopause. Yeah. Am I wrong?
No, you're absolutely. So most doctors don't know this. I didn't know this. So
I'm thinking about one of my best friend's wives who's been having strange cardiac symptoms, who happens to be in her 50s.
So palpitations are now recognized as a vasomotor symptom. So women are showing up in the ER, sweating, heart racing, anxiety, get a massive cardiac, they're getting appropriately worked up, and then everything's normal, and no one says to them, this is probably your menopause. Go see a menopause educated provider and have a discussion about whether or not hormone therapy might be something you want to consider here. And I see it time and time again in my practice. Like, these symptoms are improving, and we have the data now. Women on HRT have less of these symptoms. So we start in the brain. In perimenopause, postmenopause is easy to understand endocrinologically because we're an ovarian failure and we don't have any estradiol. It goes down to less than 1%, okay? Our testosterone's down about 50% because the source, the 50% that came from the ovaries, is gone. And then we have no progesterone because you need an ovary, a functioning ovary, to make that too. So in the brain likes to know what's coming, okay? The brain gets used to, so in a healthy woman in premenopause, we have a very predictable ebb and flow of hormones. It's not steady state. We rise estrogen mid-cycle, then it drops, then progesterone goes up. We have a little bit of a bump in estradiol after that, and then it all bottoms out and the whole thing starts over again. That is because the hypothalamus, the glands in our brain, hypothalamus and pituitary, are sending stimulatory signals to get the ovaries to work. In perimenopause, remember, we're born with all of our eggs. You guys make your stuff fresh every day. Okay, in the testicles. Our ovaries, we're born with a set egg supply, and when they're gone, they're gone. We reach a critical threshold level in our egg supply where the signals coming from the brain don't work as well. We become resistant. So sends out the FSH and LH to the ovary can't respond as well. So the brain's like, whoa, where's my estrogen? I was waiting on it. Boom, sends it, says pituitary, get back to work. Higher levels of FSH go up. Finally, we get that ovulation out. It's delayed. It causes a bigger surge of estradiol. Progesterone never quite gets to where it was before. So then we get into that estrogen dominance phase. I hate that term, but that's what happens. And then that whole thing, which used to be really EKG-like predictable, becomes chaotic and not predictable. And the brain hates it. So we see massive mental health changes in the perimenopause transition. 40% increase in mental health disorders through the perimenopause transition. Age-matched women, because we all go through menopause at different ages. So SSRI use doubles, goes from 10 to 20% in females. Doubles.
Which actually, I was going to ask you about SSRIs because that sort of tracks with my own friend group. I mean, I have so many friends who went on SSRIs in their 40s or are going on SSRIs now, and it's only been as I've become more educated myself about menopause over the last year and a half that I'm like, oh, I wonder
Turns
if they
out
would have been better served.
The data is clear.
Yeah.
You are better off in perimenopause, not post, if you have new onset or worsening of, you were well controlled with your SSRI or with your therapy, whatever you were doing, then all of a sudden it's exacerbated, or you have new onset. Estrogen is the best. And progesterone has its own benefits as well. But giving your body back what it's missing will balance out your neurotransmitters way better than the SSRIs will.
So I got one quick question because I think I really would love to dive into this idea that estrogen causes cancer. Because I feel like even among physicians, like how that happens, if it even happens, is really like, do we know that it does? If someone has ER positive breast cancer, is it because...
Let's go through that.
I mean, I just feel like
Let's go through that, because
nobody
that is
really
as
knows.
resilient, that thought process is resilient as a menopausal chin hair. So okay. So if I take an endometrial cell, the lining of the uterus, and I dump it in a petri dish and I just feed it estrogen without progesterone, you will get endometrial cancer. So yes, estrogen causes cancer if it's not balanced with progesterone in a human body. Okay. Women who menstruate regularly don't get endometrial cancer because they're constantly shedding that lining and the whole thing restarts. It's just when we take the progesterone away. So now we never give menopause hormone therapy to someone with a uterus without progestogen, to protect that lining. If I take a healthy breast cell and I dump it in a petri dish and I just give it estrogen, it's not going to cause a malignant transformation. That's not how it works. Cells that divide, mucosal cells, do eventually become cancerous if you let them divide long enough, okay, given all the environmental stuff going on or pre-genetic dispositions. So in order to have a healthy breast cell, you need estrogen. If during that malignant transformation, you retain the estrogen and progesterone receptors, you are now estrogen. That doesn't mean that your estrogen and progesterone they just held on to those receptors through the malignant transformation. Now we can use those receptors to fight the cancer cell. That's all that means.
So I feel like that's such a
But
gigantic...
that is literally what everyone thinks.
Deep. It's so deep. I mean, even amongst the breast cancer people I know, they're like estrogen. I mean, it's just thing. Estrogen causes cancer.
And I wanted to, not to call you out as a breast cancer survivor, this was a conversation we were having initially when, you were starting to feel perimenopausal and or status breast cancer. You were saying, this is what I've heard, which is this narrative that HRT is not available to me.
Yeah. And also just like back to that same narrative of like estrogen causes cancer. Like that's what you learn as a breast cancer person.
So it's like saying glucose causes cancer. You must feed a cancer cell in order to, it's just part of the food of a cell. But it doesn't cause a direct malignant transformation. There's a lot of other soup in the kitchen when that happens. The decision, what I hate for the survivors, and, Corinne Men, my God, she is like...
Yeah, if everyone should follow her.
She's incredible.
I think it's like Dr. Men, OBGYN.
And she said, your oncologist's job, what they're taught in school and their training is, and their job is done. if you never get cancer again. And if that's your goal, fine. But if your goal is also your quality of life, your brain, your dementia, your cardiovascular risk, it's a bigger conversation. And survivors are not being even allowed to participate in their own health care when it comes to hormonally sensitive cancers. And so there's good data to support in people with high risk genetic conditions. If they didn't take your ovaries out, if you had premenopausal breast cancer, explain to me if they didn't recommend removing your ovaries to save your life, why would they deny you menopausal hormone therapy?
Yeah, and there's also plenty of women who have breast cancer and then have children.
Yeah,
and
Corinne's one of them.
Yeah, and so you have this
They allowed her
to have
to
children.
get off of tamoxifen, to have a baby.
where you have a massive
And
anyway, yeah, it's really complicated. So I'd love to just circle back to the testosterone piece, because so many women have asked me about that. And I think that, again, there's this fear that testosterone converts to estrogen, that women shouldn't be taking it. And that, even, I have a couple friends who've proposed to their OBGYNs, like, hey, I've heard maybe, like, I'm not sure I want to do HRT or MHT, but maybe should I try testosterone to see if, as a sort of first order of business, to see if that works. And their OBGYNs have just said, I actually don't know anything about testosterone.
And good for them for being honest, because nothing was taught to me. Everything I learned from Kelly Casperson, Rachel Rubin, like from the Menoposse and like Ishwish and the sexual wellness societies. So here's what we know, what the data clearly says about testosterone therapy in females. If you have hypoactive sexual desire disorder, now when we look at female sexual function, we have buckets of why she may not be happy with her sex life. If she has pain, that's a whole nother animal, right? Vaginal atrophy, vulvodynia, there's lots of things there. If she has an arousal disorder, if she has an orgasmic disorder, if you have a relationship disorder, testosterone does not really help with most of those, okay? Maybe a little bit in arousal if you put it in the right place. But then we have HSDD, which is what most women suffer from, hypoactive sexual desire. That is the brain. So there are actually 2 FDA-approved medications for the treatment of HSDD in females that no one knows about. Addie and Vyleesi. So Addie works at the level of the neurotransmitters, making you more likely to be receptive to a stimulus, okay? Vyleesi works on melanocortin. It's an injection you give yourself about 30 minutes before intercourse, but I laugh. If I ever took anything like that, my husband would be like a praying mantis. Like, is it working? Is it working? Is it working?
How about now?
Are you ready? How about now?
Is it happening? Finally I just give it. But so, it's a complicated conversation, but if at the end of the day, I screen every single one of my menopausal patients for it. And so if we decide, that the desire is something she misses, that she had in the past, she's got a great relationship, she can still orgasm, she's not having pain, then testosterone is also a reasonable option for her, because the studies are clear. In a postmenopausal patient with HSDD, it is very helpful. Turns out off-label, women with the highest percentiles of natural testosterone tertiles have less frailty, less bone density issues, and there's decent data coming out showing mental health changes. It is a human hormone.
This episode of the Ready State podcast is brought to you by Momentous, and we are really excited to talk about one of our products, our favorite products that's been out of stock and is now in stock, and that is collagen shots.
Yeah, I think collagen had a big moment. People weren't utilizing collagen effectively. They were like, it's for my skin. Utilizing collagen before training is pretty profound, because now we're making sure that a lot of your connective tissue and joint surfaces have what they need on hand to be sort of repair themselves and to improve their load bearing capabilities. One of the things that is always missed with collagen is that people don't realize they have to take it with vitamin C. And so, if you're taking much collagen, don't feel a difference. A, are you loading afterwards? And B, have you taken some vitamin C with it? Every professional team I work with, a lot of them, I work with a lot of teams, they all take collagen. They give it to their athletes on the way into the weight room, on the way out of the weight room, on the way into the field and out, because they've found it to be significant in reducing sort of hot spots and little sort of niggles and pain points.
So I don't know what you're talking about, because I've never fallen off the collagen train. I'm on it and continue to be a true believer.
Well, your skin is amazing.
But one of the things I love about these shots in particular are that this summer and in the spring, we've been doing a lot of travel, both for pleasure and for work. And I love to just take a few things in my backpack when I travel so that I know I can check the boxes. I usually don't pack every supplement I take with me when I travel. But
Collagen is a food.
There's a few things I do take. And if you look in any of my backpacks when I'm traveling, I always have these individual use packs of protein and collagen shots. And I often just make sure I have those things only when I travel. And I know I can at least get those two things on board.
Momentous uses a clinically sort of validated collagen peptide, which is important. And because I don't think all collagen
they're not all
is
created
it's all the
equal.
same. So I think that's important. And then the other thing that I'm a fan of on the collagen shot is that you actually will take it because it's so easy to use. Sometimes even opening up the bag and pouring it into something is one step too far. The collagen shot increases adherence, increases utility. I'd probably double my collagen intake when we have collagen shots around.
Yeah, and to the extent we're in the wild west of supplements these days, all Momentous products are NSF certified, so you know that you are taking what you think you are taking when you have a collagen shot.
And you're not going to pop when you're, this Olympic medal that you have, because obviously you're an Olympic medalist.
If
Look,
only.
If you want to find out more, go to livemomentous.com/TRS and use code TRS for 20% off your first purchase.
This episode of the Ready State podcast is brought to you by Element.
Dude, we're in a heat wave. It has been hot this summer. We're breaking records in Death Valley, breaking records in Texas.
Yeah, I mean, we just drove home from a trip and we were driving through Redding and what was it, 118 degrees?
118.
Yeah.
We had just spent a week in the wilderness, Oregon wilderness on the river. I cannot tell you how important Element is. We had strange food. We'll put it up as a weird food trip. But one of the things that happens is that you are sweating and sweating and sweating. And I guarantee you, you're not probably supplementing with enough salt. And the Element makes it possible.
Yeah, and the other thing we were doing out in the wilderness is drinking potentially weird water that might have been filtered from creeks and rivers and
Tastes
whatnot.
weird.
Tastes a little weird.
Through the filter.
Through the filter. And so adding a little bit of Element to your miscellaneous wilderness water is also a really nice way to go.
You're in Hell's Canyon and it's deep and the water's cold. And then you have a grapefruit salt. And you're like, what's happening?
Yeah.
Yeah, it's unbelievable. In this time of heat, everybody, one of the things you can absolutely do for yourself to change how you feel is make sure you're getting enough electrolytes. We're huge fans of separating out our nutrition from our hydration. But if you are exercising in the heat, and you maniacs are, I know you are, make sure that you're adding in these salts. I can't stress enough. You'll feel better. You'll recover better. You'll absorb the water. You're drinking better.
And they're so tasty.
So tasty.
So tasty.
Right now, if you order through our link, you can get a free sample pack with all the Element flavors. And if you want a party in your mouth, you can go sparkling. Go to drinkelement.com/TRS. The Olympics has upper limits because it's such a performance enhancing. I think of Caster Semenya. You're too strong. Have too much lean muscle. You're too fast. Your cardiovascular system is too developed.
Probably because he hit the testosterone lottery, and and there are females that naturally just have higher testosterone for whatever genetic reason, and they're killing it performance-wise. That's
They
just
feel great.
a natural advantage. Yeah. So my patients love it. I started it because, I did not think there was an HSDD issue. Everyone was happy. No one was complaining at my house. I started it because I have low muscle mass genetically, and I'm just trying to bank muscle for my old lady body. And so I'm eating the protein, I'm doing the resistance training, and I'm like, this will probably help in my efforts. Because again, I grew up in the 80s. Everything I did, movement and food, was to be thin.
And let me just say that for a second. I want to double click. We have been inundated with longevity, need to put muscle on. Muscle is an endocrine machine, anti-frailty machine, health machine, function machine. And I just heard you say is, wow, there's maybe some aspect to my physiology that's making it very difficult for me to do these things, even though I'm doing them. So I could be doing all the work and having very little benefit. Am I hearing?
Yeah. So I was like, this will probably help me stack the cards a little bit more in my favor. It's not magic on its own. I know I need to do the work, working with Gabrielle Lyon. I'm, upping my protein. I'm got a trainer now, and I look at my cardio machines. I'm like, no, like don't focus on that. Like focus on muscle. And I started it. I stay in a female physiologic range. Okay. I'm not going over into the super physiologic.
And that's an important piece. Anytime we're talking about HRT, we're always talking about human specific ranges, right? When you're not super physiologic, you're not like your testosterone is 1200. That's right.
Yeah,
right.
No,
Okay.
I'm keeping it below 100, but
Which
my
is what
natural levels are about 30. I'm like, I want to go back to my 25-year-old levels. I think I'll be better there. Turns out uptick in other areas of benefit that, no one was complaining, but I think we'd miss it if it was gone. So that's kind of what I talk to my patients about. And overall, they are very happy. But again, we've ruled out other disorders that lead to female sexual dysfunction. So also when my patients come in with osteopenia, osteoporosis, and they're willing to eat the protein and do the work, I am off-label recommending testosterone therapy for them as well.
Sorry, what you've just hit on though is so many couples, in the men we talk, we try to openly talk about some of my friends like, are you intimate with your partner? Yes or no? Because if you're not, chances are you have some real dysfunction in your relationship. Like, and I'm not even just talking about the sex act. I'm talking about the desire for intimacy, the anti-flinch, right? Like, is my partner going to touch me, right?
That is such a great way to put it. The flinch.
The flinch, right?
What does he want?
and the potential countless downstream difficulty interactions with partners who have changed or some aspect of their bodies have changed. And I just want to double click on that because we're talking about health, but you are like the psycho-emotional health of your relationship.
Intimacy can be a vital sign, or the desire for it. And I think it's right up there when we talk about the toolkit. And if I didn't address that with my patients, I'm not doing them service, because some of them are embarrassed to talk about it or ask. So I just go there. And if they're not comfortable, fine, we can address this later or whatever. But like 8 times out of 10, they are like, oh my God, yes, let's talk about it. So
I just want to go a little deeper on the idea of being thin. And I was high-fiving in the air when you've been posting recently about making decisions about not being thin, because I've been posting about this for many years. And I was like, yes, another awesome woman and you were at the airport, and but I do think, I'm hoping it's generational. I feel like our generation of women who grew up in the 80s and 90s, we have like deep scarring about this need to be thin.
Tab and Virginia Slim.
Yeah, and it's deep, and I think even to this day, most of the women I know in our generation do exactly what you and I have talked about on the internet, which is eat and exercise to be thin, that's the ultimate goal. And so it's been interesting to watch, because there's this, again, also, as there is this groundswell of information about menopause, there's all this groundswell of information about longevity. And what I've seen in the female population that I know and work with, that the women are interested in it. And I think they're starting to know that they need to strengthen, but a lot of them don't
even know how, where to start, or they're entering.
They
don't from a size 0 to a size 1.
They don't know how to start it. And even if their objective brain knows it's the right thing to do, the deep scarring is still overriding their ability to do it.
I still have to pull myself back. I still have to reorient my brain every now and then. Even though I know the data, I looked at my grandmother, I watched this 10-year decline. I'm watching my mother in a horrific decline right now. And it's still hard, because it literally controlled my life, my eating habits, and all of my movement for 40 years. And so I'm trying to lead with compassion, because I've been there. I get it. I shamed patients for being overweight. I didn't understand the physiology behind obesity. Things I know now, but these are big mountains to climb, and especially in the mindset of a lot of people.
So we've alluded to a lot of them, and I'm not sure it makes sense for you to give a list, but I'm hoping maybe you can give an overview for everyone about what all the menopause symptoms are, because I actually work out with a woman named, and the context here is I work out with a woman named Mitra, and she's been having horrible tinnitus course, she's 50 years old. And I think I listened to either on Huberman or Atia. And it was the first time I'd ever heard anyone say out loud that could be a menopause symptom. So I, of course, marched right into our workout the next day. And I'm like, I think your tinnitus is a menopause symptom. And that was the first time she'd ever heard that. So I think.
And I'd like to just piggyback on that and say, what is the most surprising thing?
Yeah. And I think everybody
blows up the
knows
internet?
about hot flashes. Like, I feel like that's the obvious one that everyone knows about, but there's so many other ones that we don't know about.
So the best study, my favorite study, was one called "I Just Don't Feel Myself." Yes. I just don't feel myself. Nothing in her environment has changed. All of her stressors are the same. She's been rolling with the punches, like living her life, and then something has changed, and she can't put her finger on it. So that's really the number one. That's the first clue, and usually it's retrospective. Like, I started feeling kind of da, 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 da. The problem is, so fatigue is number one. Unexplained fatigue with normal labs. So the telemedicine companies that are coming out, this is what I love. They're collecting data. They're all run by data scientists, and they're collecting data and finding out hot flash is like number 5 on the list. Sleep disturbances, mental health changes, weight, body composition changes. Those are the top complaints that women are coming. In my clinic, they're coming in, because I started in the nutrition space, they were all coming in with, what is going on here? And so the visceral fat changes. Surprising ones that the internet blows up whenever I talk about it. Frozen shoulder. That was millions of views, in the comments. Tinnitus, however you say it, ringing in the ears. Vertigo, new onset vertigo. So it turns out, theoretically, they think that the loss of estrogen is causing the crystals to break off faster in the ears than they typically would, and that's causing the benign positional vertigo. And then musculoskeletal, the unexplained, no injury, and you're just having back pain, hip pain, knee pain, beside the frozen shoulders, adhesive capsulitis, that's a, specific thing. But the arthritis and arthralgias. My friend is publishing, Dr. Vonda Wright, the musculoskeletal syndrome of menopause, and beautiful data behind that. So excited for that, just because the validation piece. Palpitations. And there was one just came out that everyone went crazy about. You'll have to edit this out. I can't remember the name of it. Menopause. But it just seems like we just keep tripping over more and more gut changes, the gut microbiome changes.
Loss of libido
and then of course the sexual
piece. The sexual
piece is huge. So the hypoactive HSDD. So what lay people would call loss of libido, with a great partner who you love, have had a great relationship before. That was never an issue. Then all of a sudden kind of something's changed, and it's devastating to her.
So I have kind of a 2-part question, and this came in from quite a few audience questions that people want to know how they should talk to their doctor about this. That's sort of part A of this question. And then number 2, what is sort of the order of operations? Because I know that there's a lot women can do from a lifestyle perspective to minimize menopause symptoms. And sort of what would be the order of operations in terms of medical intervention? Is it lifestyle symptoms first, then maybe try testosterone, then maybe HRT or MHT? So what would be the order of operations that maybe you would be thinking of as a clinician that you would start working with someone on?
So I wish you could just confidently walk into your primary care, your OBGYN, your family medicine doctor, and expect to have a reasonable conversation about your menopause. You only have about an 8% chance of that happening currently.
In 6 minutes. So what's 8% of 6 minutes? Great. That's going to be great.
So, and we're not training our clinicians anything clinically relevant at this point. We're training them to ignore, and we are training them that that females somaticize psychological issues. So it's all in her head. Is still a thing. So that's a problem. So you need to find a menopause educated provider. In the book, I have a list of questions on kind of how to get rolling or things to have prepared so that you can economically, time-wise, get the most out of your visit. I have an hour with my patients because they've got a trauma dump, their menopause story, which is fine. That's my job, and everyone has a story because of all these organ systems and that we're all biologically individual human beings. each of our menopauses looks very different. And in medicine, we like ducks. Walks like a duck, talks like a duck. It's a duck. The menopause duck is really weird. Now, certainly if she has no period and tons of hot flashes, that's pretty clear, you know. But what if she didn't have hot flashes, or she's had a hysterectomy and she's having mental health changes, palpitations, ringing in the ears, you know, life disrupting things. So she ends up going to see 6 different specialists. You know, one of the Lancet article points was we are over medicalizing menopause by offering all these women hormone therapy. Well, when 4% of the or 6% of the population in the U.S. is on, who could be on hormone therapy, is on it. I don't think, but she's on an SSRI, a beta blocker for her palpitations, a, you know, antidepressant, a anti-anxiety meds. She's on, you know, Celebrex for her hip pain, back pain, knee pain. I really feel like that's over medicalization rather than treating the root cause.
Here. That's a great point.
Seriously.
You know, and we're telling her to get more sleep, lose weight, and just drink wine to have sex with her husband. I mean, that's what's happening. This is the reality. And then 30 years down the road, she's got Alzheimer's and frailty because we're not addressing. So how in my clinic, what do we do? So I come in, I do a full assessment. I'm checking lots of labs, because a lot of things overlap. Is this hypothyroidism as well as menopause, or you know, is it an autoimmune thing? Is she, depending on her symptoms, is this psoriatic arthritis? Is this, you know, I've diagnosed lupus in my clinic before. I don't want to miss those things because all of that can happen instead of or in along with. But I'm not doing a lot of hormone testing. I tend to believe my patients. And, you know, rule out the overlapping things and then move forward with therapy. So we begin a conversation around pharmacology, replacing the hormones your body will no longer make for you and what that might look like for you. I start with estrogen and progestogen, and then we add in testosterone, especially if there's a libido issue. So, and then we can talk about the kind of off-label recommendations for testosterone if that's something she's interested in. We do a deep dive in lifestyle. We look at how she can approach her nutrition. What's her protein intake? What's her fiber intake? What are her added sugar intakes? I have them track their nutrition, and those are kind of the things, you know, her vitamin D, her magnesium. These are the things we hit kind of hard. We look at her movement. If she's on the couch, we start walking. If she's walking, we throw on a weighted vest. You know, we start talking about adding in resistance training and what that might look like and how to do it safely. And here's some people I follow, and here's some YouTube videos, and try to get it, you know, if you can afford it, get a trainer to help you who knows what they're doing and isn't going to shame you, you know, who really wants to be a partner in your health. And then we talk about possible supplementation. Is she not able to get enough fiber? Is she not able to get enough vitamin D? Many of us can't. So, you know, magnesium, is she have a deficiency? But sometimes a little extra magnesium can be medicinal for sleep and anxiety. So we have a conversation around that. We talk about putting up boundaries, stress reduction, sleep optimization, turning off the phones, as I'm pointing to mine over there, you know, at night, the blue light, like all the things to set environments so that we can thrive and our body can heal and rest.
What
while
you're
we're
not
sleeping.
describing is being a physician, by the way.
No one taught me this.
We need, can we have a new term for this level of care? And so
why isn't it standard?
Isn't it
Well, how have we gotten to this point
in
in Western
strength and conditioning
medicine?
now? What we're in our teams, we start to talk about it. We have a high performance director, and this high performance director is looking at the whole thing and pulling in experts from other pieces. And what you just described is what we want for every team we've ever had, is a person who can look systematically at all of the
Make
complex
connections.
systems and see how these systems interact. It's incredible.
That is what I want for every patient, but just the way that the medical system has evolved is not happening. We put Band-Aids on things that break.
And
then we blame the patient for that
that's
happening.
Right. You are setting people up to have control over a lot of the things you're describing in here. So you don't have to feel like you can say, hey, I've done these things. Now I'm ready for the next conversation. I want people to understand there's a lot they can do themselves in their kitchen, in their home, that now we can get to I can really use my physician better.
And in my patient population, which are mostly my age-ish, so 40s to 60s, and I'll be 56 next month, they want better options that their mothers had. They want a better future than what was laid out for their mom. and they want way better for their daughters. And they want to set an example for their children who are in their 20s, teens, whatever, that what happened to grandma is not inevitable. This is your genetic path if we stay the status quo, probably. But we can make some interventions here, but it takes a village. It's not just slap an estrogen patch on someone and send them on their way. It is, all of these things are important and they can work synergistically together.
And I just want to say that we had seen a similar patch towards men. And I'm not trying to just bring us back, but we in our military, they were putting huge testosterone pellets in guys' butts and then sending them overseas. And they hadn't mitigated any of their lifestyle. They hadn't looked at nutrition. They hadn't looked at stress. They hadn't looked at sleep. And guess what? We got exactly what we thought when we had these super massive, super physiologic doses of testosterone backing up the system. You don't get something for nothing. And because they hadn't addressed a systems approach, we had less than advantageous outcomes.
So how do, I think that I think it's well understood that a lot of women feel like they're getting gaslit by their physicians, and that we also tend to minimize our own symptoms. And I don't know if there's like a test or something, but how do women know if their symptoms are enough to require intervention? And again, I go back to hot flashes. That seems obvious. Like if you're having a bunch of hot flashes.
That's a great question. What if you just wake up one day and you never have another period and you feel no different? So
does that happen?
Why would you consider rarely, but yes, of course, what if, or I'm like, well, first of all, how's your cholesterol? What's your insulin resistance? Like there may be things happening that you don't realize or never put together. Okay. So turns out most women are having something. They just didn't know that could be their menopause. But what if you're magical and you just feel amazing and everything's great? What could hormone therapy do for you? Decrease your risk of cardiovascular disease and death from cardiovascular disease in the form of atherosclerotic coronary artery disease by 50% per year if you start young enough. Decrease your risk of osteoporosis by 50%.
Wait, you're saying a Vivactin calcium chew? Just eating a little piece of chocolate with some calcium didn't solve the problem?
So it turns out calcium oral supplementation has never been shown to decrease the risk of an osteoporotic fracture.
So tasty, though. Isn't that crazy?
Never.
Was
you know
that
what
the
it does?
90s
It
and
gives you
2000s?
kidney stones.
That was like early 2000s. We were eating those things like it was
the
our job.
yeah.
I would like eat them for dessert.
Unbelievable.
That's
So-
amazing.
So I tell my patients to get their calcium from food.
Yeah. What about women because they've had breast cancer or for other reasons don't want to or can't take HRT?
So let me be
what are
clear
those
to your
folks-
listeners.
Yeah.
You can be healthy without hormone replacement therapy.
I know there's so many options, but what
It's
is
hard.
out there?
It's just harder. Yeah. You must double down on all the other pillars of health.
Yeah. Yeah.
So, but yes, you can do it. But it is just harder. And I prefer to take the path of least resistance. I want my hard to be in the gym. So, yeah.
So I'd love to just, since we're the musculoskeletal people, I'd love to talk a little bit more about that piece. Mags, who works for us, got frozen shoulder in both shoulders 5 or 6 years ago. I don't even know. Did you realize that was a menopause thing at the time? Okay, you did because of your training, but it again wasn't until
But
very
the study
recently.
didn't come out of Duke until the last few years.
Yeah. So
and it was the head of OB-GYN.
We knew that there were changes in tissues because estrogen was cellular protective.
So it turns out estrogen is a really powerful anti-inflammatory hormone. And when we take that blanket away, then kind of things that never bothered you before tend to bother you, and you become more inflamed, especially in the joints in the form of
and if I'm
and
correct me
arthritis.
if I'm wrong, also that we start to see a lot more delayed onset muscle soreness because those cells aren't as protective, not as robust when we pull out estrogen. Is that right? Also.
Right. And the response also, they're now looking, I guess the Stacey Stem's world is looking at, you can build muscle without HRT in menopause. It's just a lot harder. So
and already
our
we have a
response
lifestyle
to the stimulus of
and we
is
already have
just
a
less.
lifestyle bias against it.
Right.
And a cultural sort of taboo. Hey,
Right.
we're going to go in and do heavy squats today. And like no woman raises her hand. Very few
Right.
women. That's not true. Very few women are going to be like, sign me up for that.
Right.
Right. That's not how I even enjoy my time. I don't even enjoy it.
Yeah. So I would be remiss if I let you go without talking about weight gain, which in my own friend group seems to be the number one biggest complaint. And Is it a myth? Like, is it just in our heads, so to speak, that we have weight gain issues as we go through perimenopause and menopause? And I realize this also could be a whole podcast in and of itself, but what is the role of GLP-1s? And also, in many cases, for women who are like plus 15 pounds, but feel horrible and sad about that, but they're not, they wouldn't qualify through their regular physician for a GLP-1.
No, it's a great
Right, so this
conversation.
is like
So
this
let's
complicated.
Define
weight-
GLP-1 for people.
I mean, like Ozempic or
Wegovy and Mounjaro.
Yeah.
So the incretins is kind of what we call them in medicine. So they've looked at this data a lot in females, and women gain weight with age regardless of menopause status. However, their body composition changes. So you, as a premenopausal person, age matched, in general, on average, we have 7% of our total body fat is visceral, which is the intra-abdominal fat. Different than subcutaneous, hips, curves. We've been we've been programmed socially to fear subcutaneous fat, to call it bad, to think it's ugly, to think, make us fat. Visceral fat is a very different animal. Visceral is the fat that wraps around our omentum and our intra-abdominal cavity, and that fat is metabolically much more active in the inflammatory world. So the higher your level of visceral fat, the higher your level of cardiometabolic disease risk. Waist-hip ratio is a better predictor of cardiometabolic disease than your weight or your BMI, okay? So 7% premenopausal woman, same woman, take her through the menopause transition, we get up to 23%. 0 changes in diet and exercise. Just
So it's not in their heads.
That message is struggling to get through the wellness world, but we're getting there, okay? Because calories in, calories out. I can't tell you how many fitness bros come on my page and start screaming at me about calories. I'm like, no one is negating the laws of thermodynamics, but we are complicated machines, and there's more things at play here than just how much you eat. I mean, it's important, right? So quality of food matters. It affects on inflammation. And so hormones drive the loss of estrogen, increases inflammation. Inflammation drives fat to the viscera. And visceral fat starts increasing insulin resistance and risk of diabetes, of course, blood pressure, all of that goes up across the menopause transition. So GLP-1s, and then you're gaining weight as well. And so women just see that number on the scale and they freak out, and makes them really uncomfortable. And now their pants don't fit and their waist is increased and all that happens. So I've spent a lot of time with obesity medicine specialists and lots of deep conversations. So, medically, they're helping a lot of people. They are keeping them out of heart attacks and diabetes. And I can't tell you, anecdotally, patients coming in talking about whether they got it from me or from another provider, that they are decreasing blood pressure medication, diabetes medication, aches and pains, joints, all the things are getting better. There's a great study looking at women on GLP-1s in menopause and women on GLP-1s plus HRT, and the women on HRT lost 30% more weight. Now, I don't know if that's sustainable, and we're still looking for the sustainability data, right? I think it's a tool, just like HRT. And I think it has risks and benefits, just like any other medication. And what I worry about, because of the frenzy and that a lot of people are getting it, and they're not getting it properly. They're not getting proper counseling. Here's your miracle. Bye-bye. And
or you're getting it from non-reputable sources.
Right.
I want to just double click on that.
So this relentless pursuit of thinness that has nothing to do with health. Certainly if you're morbidly obese, being thinner will most likely improve some health benefits. But what about the woman who has 15 pounds to lose? When we calorically restrict, we tend to lose muscle as well, especially if we're not eating enough protein and resistance training. And most women are not thinking about that, are not being taught about that, and don't understand that. And so what I tell my patients is, we don't want to sacrifice your muscle to get to a number on the scale. I'm not willing to do that, because long-term you're going to end up way worse off. So my friends who I feel like are doing this well, who have taught me how to do it, and I have a handful of patients on it, We are monitoring their I have a body scanner. So we're monitoring muscle mass, visceral fat, and
Are you using it in body?
yeah, I have the 770 in-body scanner. And so we're bringing them in every month if they're choosing the GLP route. And we are, we're going heavy on protein, heavier, and like 1.6 to 1.8 grams. And those were where the 1.6 to 1.8 gram per kilo was where the frailty scores were the lowest in the menopausal patients in the W.H.I. That's where I get those numbers. And so even though the FDA is recommending 0.8, I'm doubling that.
Well, it's nice not to have rickets, so you should probably have some. Right? It's nice to have scurvy. I think.
Yeah,
that's we
that's
can have
all
these
I learned
minimums.
about
That's
nutrition
right.
in medical school.
We
was
have these
scurvy and rickets.
benchmarks now.
Yeah.
You're so.
So
Yeah, that's what we have that exact number in our book, Built to Move To, from a protein perspective.
So that's where I set them, and they get it. They know. We talk to them about how important muscle is as they age and
so
sustaining
difficult to
weight
change these
loss
lifestyle
and
pieces.
and so I think it can be done well. I think it can be an important tool, but giving it in isolation without proper counseling, I think might lead to an epidemic of osteoporosis and sarcopenia if we're not careful.
Ozempic butt.
Ozempic face.
Yeah, it's because you've lost all your muscle mass and your butt goes away.
And you just have hanging skin.
Yeah. Sorry, everybody. It's true.
So I think it's a tool, and it can be abused or used properly.
What I just want to circle around for a second because I don't want to diminish any of the conversation, but I want people just to appreciate that your approach is so holistic and so systemic. I've met two physicians who look at body composition, and they're just such outlier physicians. So even for a physician to actually track that, measure that is so miraculous. And that for people hearing this, there are no quick fixes, but it seems to me that there's a lot of great conversations we can have with our physician while we're simultaneously working to change behaviors at home, because that's the hardest thing we can do is to try to sleep a little bit more, try to eat a little less ice cream, try to resistance train. Those things just don't happen
Eat a little
overnight.
more veggies,
But I just want to remind everyone that a lot of the things that you said, we talked about symptoms that were acute and today, which are really important. But you also have been highlighting that we're playing a long game and that we're really talking about the quality of your life and trying to reduce your risk for some of these diseases for the long haul. And I just want to circle around that we should be playing the short game and the long game simultaneously.
And HRT can kind of be a part of both of those things. And the conversation's been so limited to the short game and only like the most cliche symptoms of menopause. And so, but the word is getting out there.
It is. It's
and
changing.
women are really recognizing, I count, I matter, my life after I'm done having children should be, to leave your listeners with anything, I'll be 56 next month. I am literally living my best life. I am wealthier. I am healthier. I have better relationships. I am reaching more people. I'm teaching. I could not have built a better life for myself. But had I not done the things, including HRT, including nutrition, including movement, including all of those things, I would not be here today. And where I'm meeting patients is a shell of what they could be.
Yeah. I love that.
And I want to get them to where I am. I think every woman deserves that option.
Playing offense versus playing defense.
Yeah.
I love playing offense. And I think that's really, you actually can feel better and do more. That's amazing.
Yeah.
So I've got a few questions that people submitted from Instagram that I want to just ask. And some of them we've covered a little bit, so I'm going to try to skip those ones. But I'll start with, this is from a veteran nurse, age 52, weird stuff happening. She's wondering why most physicians don't check progesterone levels. And her question is, how many women find out they have a neuroendocrine or adrenal tumor after saying it's menopause? That seems very specific, but
neuroendocrine's a pretty rare tumor, and those are really rare. So I don't know that data off the top of my head. I can certainly try to research it. We are not training and educating our providers for much that is clinically relevant in menopause, and that is one of my platforms, is putting pressure on not just the American College of OB-GYN, but like every medical specialty that touches a female should have at least basic knowledge about this and how menopause affects that particular specialty.
And physical therapists and strength coaches, if you're listening to this, you may be the gatekeeper to initiate these conversations with the person that you're working with so that she can talk to her provider. Hey, this doesn't smell like you're sore or that you've overdone it. Or, hey, I'm seeing you 3 to 5 times a week. There's something going on. You don't seem great. Or you're reporting this. Hey, maybe this is something I've heard about. Now let's initiate conversation.
So in our world, in the Menoposse, there's a big thought process around that fibromyalgia is probably just menopause. Most of it. Misdiagnosed menopause.
So this is from my friend Adrienne. She says her OB told her to only start HRT if she has intolerable symptoms.
That was very much the old way of thinking.
Yeah, and she
That
said, but
is
what about
not
the longevity benefits?
Right. We're not teaching the longevity benefits. They don't have time to keep up with the latest research or join the Menopause Society. So my advice to any healthcare provider out there, take menopause out of your scope of practice. Don't put it on your website. Don't, if you are not at least going to go and get certified by the Menopause Society.
I like that.
I like that.
Just do what you do well and let us take care of the rest.
Yeah, find the provider who's can do this.
Yeah.
That's great.
So a couple people have asked this. They're like HRT curious. Where they're wondering, like, where do I even start? Like, and I think in some cases they're like, which physician do I go to? Like,
Right.
do I go to my primary care? Is
Maybe.
this always OBGYN?
So-
Where do they begin?
The Menopause Society certifies providers, clinicians of multiple specialties. So you don't have to be OB-GYN or,
Is that the menopausesociety.org?
menopause.org. Yeah. So they have, but you want certified, look for the certified check because they took the test. Okay. They have all their members listed, but that's one way. It's not perfect, but it's one way to start. On our website at The Pause Life, we have testimonials from people all over the country, and we just compile them and put them in a list, and maybe there's someone in your area. And honestly, there are some great telemedicine options coming. And these are companies, there's some not great ones, but these are companies started, they're mostly female founded, and they saw a gap, they saw a need, and they were like, we can fill this. We can provide evidence-based, good quality menopause care to women who cannot access it in the traditional way because...
I just want to point out, everyone, this experiment has already been run for men for a long time.
Oh yeah, HIMSS. Yeah,
HIMSS.
They looked at the HIMSS model.
This feels crazy, by the way.
And said...
That's right. We can do this safely.
Are you able to say who some of those
so
companies
my
are? 'Cause I know
favorites,
people will ask.
my favorites are, and they pay me nothing, so I am not on the payroll here, Evernow, MIDI Health, and Alloy Health. And MIDI takes traditional insurance. They're more of a traditional model. Alloy and Evernow have different, they don't take insurance, but they can give you prescriptions. You can go and get filled with your insurance, and some of them own pharmacies and can get you really discounted prices. So, on our website, we have the three of those side by side and kind of, pluses and minuses, and you can go and compare and make a decision that's best for you.
Amazing. Okay, I've just got a couple more here. For people who are on HRT, do they assume they're going to take it the rest of their life?
They could. So as long as for you, the benefits outweigh the risks, there's no age at which you must stop. Like I joke that I might die with my estradiol patch on.
If you're lucky.
So this is a weird one. This is someone who appears to have perimenopause symptoms, but they're on the pill. So their doctor has told them that they can't be experiencing perimenopause symptoms because they're on the pill. Is that true?
We don't have a lot of data there. No one's studying that. And so my symptoms were completely masked because I was on continuous birth control pills. So if she's on the traditional 21 days on, 7 days off, are her symptoms flaring in her week off? That's one kind of clue. The other is, to take her off for a few weeks and check some blood levels and see where she's at. So, but I can't say it's impossible because we have not done a single study on that.
Hopefully
is
that's
that
coming.
because women don't take the pill and go into perimenopause? Is that why we don't have any studies on it?
So you're
I'm just
still
kidding.
going through ovarian failure in the background, but we're feeding the hypothalamus pituitary estrogen 21 days out of the month.
I just can't believe
I
there's
was
no
on
studies on it.
continuous because I hate periods. And so, my perimenopause was masked with birth control pills because I have another condition I was treating, but I don't like having a period. It's inconvenient for me. So I just took continuous birth control pills. So, and then when I got off of them is when I was fully menopausal. It took me about 6 months to figure out myself.
Yeah, you're like,
and I was the expert.
yeah, you're like,
You know?
Okay, this is the last one. This is for someone who's on HRT. How do they know if they're taking the correct dosage?
Well, one, if their symptoms are gone or much improved. So we don't know. Like, all we know is that women on HRT do better in X, Y, and Z disease state. No one was checking blood levels. No one was comparing formulations. We're like, it's archaic what we've done. So if your symptoms are controlled, then fine. I'm also kind of watching their cholesterol because that does tend to get better on HRT. And sometimes I'm considering a dose adjustment to try to get that LDL down.
Amazing. So you are so rad.
Aw.
And this has been such a great, like, we were so excited for this.
This may be the most important podcast we've ever done.
And
Aw.
I can't recommend to everyone listening to this, and this includes all you men, especially all the physical therapists, clinician, coaches we have listening to this podcast, that this book is so important to read because, you know, you're coaching women and working with women all the time, and you may be missing a lot of their signs and symptoms as you work with them.
And you've already gotten better working with young women and women in the prime of their sport. Now let's just continue that education. Women aren't small men, comma. Now let's go ahead and just do life care.
And we'll, of course, be linking to all the resources that you mentioned in the show notes so people can check that out. But where can people find and follow you and all the work you're doing?
Everywhere on social media at Dr. Mary Claire, and our website is The Pause Life. So we have free resources, how to find a doctor, what questions to ask, labs to suggest. You know, I try to make that all available. Tons and tons and tons of resources on, you know, different medical conditions and how menopause may be affecting that, and that's all free.
Oh, I have so many studies that
And
I need
then
to do.
you're,
This is so
you're
great.
Dr. Mary Claire on Instagram, right? Okay. And then just before we let you go, what are you looking forward to? And I know you have a book, another book on the horizon. So maybe you could tease that a little bit and tell us just what are you looking forward to?
So I'm going to develop a training program for clinicians. I am so excited
Yeah.
about
Yes.
because I can only see X amount of patients in a day and teach and go on podcasts and do all the things. But I want to leave a legacy behind me of menopause educated providers, those who are interested, because they have to go outside of their training right now to get it. So I'm working hard to launch that by the end of the year. And we have the Menopause conference coming up in January in Galveston, Texas. So, and there'll be a digital option for anybody and it's 23 clinicians. We're bringing in the Menoposse to all come and teach. We're having Mohit Khera, who's an expert in testosterone. You know, we're having Gabrielle Lyon. We're having Avram Blooming and Carol
Just so we're
Tavares. You know, these are like
Can just members of the
absolutely.
crowd
It's really
attend?
for lay people, but
Oh.
we're bringing in all the docs.
So good.
And we did something similar last January on a cruise ship. We brought 100 people, but we had a digital option, and we brought 8 experts in. And it was, I walked on that cruise ship thinking, this is the craziest thing I've ever done. What the hell am I thinking? I walked off in tears. It was the most for me, educational, wonderful experience, and so bonding, and just letting everyone tell their stories and listening to all these experts. And there, you know, Corinne Men came, Vonda Wright came, and just like, we've got this. We've got this. You know, we have the experts, we have the tool, we have the knowledge. We just need to spread and share.
Amazing. And think
Thank
about
you.
how rad this is going to be for our daughters.
I know. Like,
Right? I mean,
my 24-year-old's like, menopause isn't even going to be a thing.
Yeah, I
like,
mean, they're going to have it so covered. So thanks to you and all your amazing work. And thank you so much for being
Thank
here
you
today.
so
thanks
much.
for having
So
me.
much.
Awesome.
Thank you for listening to the Ready State Podcast. If you like what you're hearing, check out all our episodes here or at thereadystate.com. And be sure to subscribe and leave a review on iTunes to help others find our show.
Check us out and follow us on Facebook, Instagram, and Twitter at The Ready State.
Until next time, cheers, everyone.
You got it.